Every 40 seconds, somewhere on Earth, a stroke strikes. By the time you reach the end of this sentence, another brain has been hit. Each year, stroke claims nearly 6 million lives worldwide, ranks as the second leading cause of death globally, and stands as the single greatest driver of permanent disability. The part no one communicates clearly enough. In a substantial number of cases, the brain issues very specific advance warnings, hours or even days before the major event. You simply have to recognize what those warnings look like. If you value health information delivered in straightforward language, no theatrics, no varnish, subscribe and tap like. We're working toward 100,000 subscribers, and your support genuinely moves that number. Stroke isn't simply a matter of, you were fine, you collapsed, you woke up in a hospital bed. In the majority of cases, stroke is the foreseeable culmination of blood vessels that have been quietly deteriorating for years. If something is foreseeable, it's at least partially avoidable. That's the entire reason this video exists. When people use the word stroke, they're actually describing two fundamentally different events occurring inside the brain. The first is a hemorrhagic stroke. A blood vessel within the brain ruptures. Blood spills into or around the brain, forms a mass that compresses surrounding tissue, and a significant proportion of those patients don't survive. The second is an ischemic stroke. The vessel doesn't tear, but becomes obstructed. Blood flow to a section of the brain halts, and the brain cells in that region begin dying within roughly 4 to 6 minutes. Ischemic strokes account for approximately 85% of all strokes. That's where I'll focus today. To appreciate why every minute counts, you need to understand just how demanding your brain truly is. It weighs roughly 1.4 kilograms, about 2% of your total body weight. Yet it consumes around 20% of the oxygen you inhale and approximately 25% of all the glucose flowing through your bloodstream. It's a command center that never powers down, and it requires an unbroken supply line. Sever that supply for even a few minutes, and cells begin dying in ways that cannot be undone. That's why physicians describe stroke as a race against the clock. It's quite literally a race to rescue brain tissue before it's lost permanently. Most people overlook what I'm about to explain. For a brain artery to suddenly become blocked, the stage was usually being set for years. The vessel walls have been sustaining damage, cholesterol and clots have been accumulating, the opening has been progressively narrowing. This isn't an explosion that materializes from nowhere. It's the final step in a long, gradual process. Along that road, your body typically dispatches warning signals. The trouble is, no one ever taught you how to interpret them. In medical terminology, those early warning shots are called a transient ischemic attack, or TIA. Transient simply means temporary. It arrives, and then it passes. Imagine a carotid artery, the principal neck artery that ferries blood from your heart upward to your brain. Across years, a fatty deposit forms on the inner wall right at the point where the artery branches. The passageway slowly constricts. Then, at some juncture, the already tight vessel goes into a brief spasm. Blood flow ceases for a few seconds or minutes, and the brain territory supplied by that artery essentially goes dark for that short interval. You see or feel a stroke symptom. Then the spasm subsides, circulation resumes, the symptom fades, and you convince yourself you're fine. What the evidence actually demonstrates is that a transient ischemic attack very frequently precedes a major ischemic stroke, typically within the following 72 hours. Those 3 days represent your window during which catastrophe can still be averted. Most people squander that window because the warning episode was brief, peculiar, and then resolved on its own, so they persuaded themselves it wasn't worth taking seriously. These warning episodes typically persist from about 30 seconds to perhaps 10 minutes. That's precisely why they fall through the cracks. You could be in your kitchen, in the shower, stepping out of a car, and by the time you pause to reflect, the symptom has already vanished. But each of those episodes is your brain issuing a final, unambiguous message. I am on the verge of serious trouble. I want to walk you through the 5 major red flags, explaining not only what they look like, but what's actually happening inside your body each time. Warning sign 1. Momentary blindness in one eye. You rise, walk toward the kitchen, and without warning, one eye goes dark or hazy, as if someone drew a black curtain across it or smeared the lens with gray film. You blink several times, perhaps rub the eye, and within seconds, or at most a minute, your sight returns. So you chalk it up to getting up too quickly, or too many hours in front of a screen. In reality, that curtain is almost always a tiny clot or a small fragment of plaque that broke free from the wall of your carotid artery, traveled upward, and briefly plugged the artery feeding the eye. The artery supplying your eye isn't some isolated, unrelated vessel. It branches directly off the internal carotid artery that nourishes your brain. When that clot or plaque fragment lodges in the narrow eye artery, blood cannot pass through. The retina, the light-sensing tissue at the back of the eye, loses its blood supply for a moment, and you perceive darkness or a smear instead of a clear image. When the clot drifts free and circulation restarts, vision returns, and you feel fortunate. And you were fortunate, because that very same clot could have deviated by 2 millimeters, entering a brain artery instead. And then, rather than a 1-minute visual blackout in a single eye, you'd be facing permanent loss of speech, paralysis of an arm and leg, or death. The classic Latin term for this one-eye blackout is amaurosis fugax, which translates literally to fleeting blindness. Neurologists treat that phrase like a fire alarm. If a patient describes such an episode, they receive urgent evaluation because the probability of a full stroke in the coming hours is elevated. Clinical records reveal a recurring pattern in which a person dismisses 2 or 3 of these eye episodes, and the very next one strikes the brain. Warning sign 2, abrupt numbness or tingling on one side of the body. The medical term is paresthesia, but you can think of it as your skin behaving erratically. It can affect the entire arm, just the hand, half the face, or even a full side of the body. It feels like pins and needles, like cotton wool, or as though that body part has turned to rubber. The critical detail is that it materializes without provocation while you're simply sitting, walking, or conversing, lingers for a few minutes, and then resolves on its own. You've probably slept on your arm at some point and experienced numbness from nerve compression that clears once you shift position. That's a different phenomenon. In that case, your brain and spinal cord are functioning normally. You compressed a peripheral nerve, and once blood flow and positioning normalize, sensation comes back within a minute or two. With a TIA, the problem isn't located in the arm. It's in the brain region that maps sensation from that arm, and the episode has nothing to do with how you were sitting or lying. One additional point worth noting. Stroke symptoms are typically one-sided because each brain hemisphere controls and receives sensation from the opposite side of the body. When both hands go numb symmetrically, that more commonly suggests a cervical spine issue. But sudden one-sided numbness that resolves after a few minutes is a compelling reason to be evaluated for TIA and stroke risk. Warning sign 3, sudden loss of coordination. What people describe as walking like they're intoxicated despite having consumed nothing. You're on a flat, familiar surface, and out of nowhere your foot lands where it shouldn't. Your leg feels weak or unsteady, or you lurch into the wall for a moment. Or you're struck by a sudden, intense spinning sensation that makes you seize a chair or a door frame, even though you weren't spinning, you didn't jerk your head, and you didn't just climb out of bed. The brain region responsible for maintaining balance and orchestrating smooth movement is called the cerebellum. It's situated low at the back of your skull, like a compact secondary brain. It continuously calculates where your body is in space and how much force each muscle should generate, so that you walk in a straight line rather than weaving. The cerebellum receives its blood supply from arteries that ascend through the bones of your neck into the rear of your skull, what physicians call the vertebro-basilar system. If blood flow through those arteries drops sharply, even for a few seconds, the cerebellum essentially misfires. That's when you suddenly veer sideways, misplace a step, or experience violent dizziness with no apparent cause. In clinical practice, a recognizable pattern emerges in which people dismiss these episodes as ill-fitting shoes, fatigue, or a blood pressure fluctuation, only to discover later that they were cerebellar transient attacks. Benign dizziness typically has an identifiable trigger, rolling over in bed, turning the head rapidly, a known inner ear condition. But spontaneous, severe dizziness accompanied by any difficulty walking in a straight line should be treated as a possible TIA until a physician has ruled out a vascular origin. Warning sign 4, sudden breakdown of speech. Before we continue, I want to clarify something. If you occasionally can't recall your neighbor's name or temporarily lose the word for toothbrush, that isn't a stroke indicator. That's an ordinary tip-of-the-tongue moment that occurs more frequently when you're tired or under pressure. What alarms neurologists is something quite distinct. When your speech suddenly disintegrates so severely that even you sense something is seriously wrong. There are two primary speech regions in most people's brains, both typically housed in the left hemisphere. One area, commonly referred to as Broca's area, helps you construct words and dispatch clear instructions to the muscles of your tongue, lips, and jaw. When that zone loses its blood supply, you may comprehend everything being said to you, you know exactly what you want to reply, but you can't produce the words. They emerge slurred, fragmented, or stuck. The other area, commonly known as Wernicke's area, helps you decode speech and organize your own sentences so they're coherent. When that region is compromised, a person may speak fluidly but produce complete gibberish, resembling word salad, and may be unable to grasp simple phrases directed at them. If any of these speech disturbances appear suddenly and then dissipate after a few minutes, that's a hallmark of a TIA, not simply being overtired. You cannot dismiss fractured speech just because it resolved on its own. That's equivalent to your home security alarm sounding, falling silent on its own, and you deciding it was probably nothing. Warning sign 5. Vitiligo paired with new, atypical headaches. This one is less intuitive and catches most people off guard. Vitiligo, patches of pale or entirely white skin where pigment-producing cells have ceased functioning, is an autoimmune process, meaning the immune system begins attacking your own pigment cells as though they were foreign invaders. When your immune system misfires in that way, it frequently doesn't confine itself to a single organ. In many individuals, that same autoimmune activity can quietly inflame the inner lining of blood vessels as well. That inner lining is called the endothelium, a microscopically thin layer of cells that coats the interior of every artery like an ultra-smooth, non-stick surface. When the endothelium is intact, blood components glide past and nothing adheres. When it's damaged by inflammation, it becomes rough and scarred. Substances start clinging: cholesterol, platelets, various inflammatory proteins, sowing the seeds of plaques and clots over time. Vitiligo alone doesn't condemn you to a stroke, but if on top of that you develop frequent, unusually intense headaches that deviate from your normal pattern, that combination warrants a thorough vascular investigation rather than a wait-and-see approach. Headaches in general are deceptive because many people blame compromised blood vessels when the actual source lies elsewhere. A very common cause of daily or recurring head pain is deterioration in the small joints between the second and third cervical vertebrae, essentially arthritis in the neck. That joint wear can irritate adjacent nerves and radiate pain upward into the head, which has no connection whatsoever to a brain artery being blocked. On top of that, many people harbor an undiagnosed cervical disc herniation. Left unaddressed, in serious cases it can threaten the nerve supply to the arms or legs. Headaches shouldn't simply be suppressed with painkillers indefinitely. They need to be investigated with a physician, especially when they shift in character or coincide with other warning signs like those we've just reviewed. Now I want to discuss what truly ravages your blood vessels from the inside, because this is where one of the most widespread misconceptions lives. The myth: my cholesterol is in the normal range, so I'm protected from stroke. Stroke risk isn't solely about what's circulating in your blood. It's equally about the condition of that endothelial lining on the inner surface of your vessels. Recall the non-stick pan analogy. While the coating remains intact, food slides right off. Once you scratch and gouge it, everything begins sticking and burning. The first major adversary of the endothelium is chronically elevated blood sugar. Glucose is your cell's fuel, but to pass from the bloodstream into endothelial cells, it requires insulin, the hormone that essentially unlocks the door into the cell. When your body produces insufficient insulin, or your cells become resistant to it, you can have abundant sugar in your blood, while the vessel lining cells are still deprived of nourishment. Starved cells sustain damage, lose their structure, and can even detach from the inner surface, leaving behind rough, scar-like patches. Those scarred zones can no longer contract properly when blood pressure fluctuates. Clinicians call this a loss of vasomotor reserve, meaning the vessel has forfeited its flexibility. And those rough patches serve as ideal docking sites for LDL cholesterol, platelets, and other blood constituents. Over time, these accumulations develop into the plaques that narrow and stiffen your arteries. This process begins years before anyone formally diagnoses you with diabetes. Even mild prediabetes, where your glucose sits only marginally above normal, is sufficient to injure the endothelium silently over an extended period. The second major vascular antagonist is smoking. Cigarette smoke contains thousands of chemicals, and dozens are established carcinogens. But in the context of stroke, the specific concern is their impact on the endothelium and on the blood itself. With every cigarette, toxic compounds strike the inner surface of your vessels and inflict direct chemical damage and inflammation. Simultaneously, nicotine and carbon monoxide render your blood thicker and more adhesive, increasing the ease with which platelets aggregate and clots take shape. When you combine a damaged, inflamed vessel wall with viscous, sticky blood, you create optimal conditions for a clot to obstruct a brain artery. That's why smokers face roughly 2 to 4 times the risk of ischemic stroke compared to non-smokers with comparable cholesterol and blood pressure profiles. Blood pressure introduces yet another layer of complexity, because the prevailing misconception here runs in the opposite direction. Many people have heard that stroke stems from elevated blood pressure, so they're terrified by a high reading and reassured when the number is low or normal. Chronically elevated blood pressure is unquestionably one of the most potent risk factors for stroke, because over years it physically strains and weakens vessel walls while accelerating plaque formation. It's also the primary force behind hemorrhagic strokes, where a vessel literally gives way. There's a twist, however. An ischemic stroke frequently occurs not at the peak of blood pressure, but during a relative trough. Picture a brain artery already narrowed by more than half due to plaque buildup. It's like a water pipe that someone has clamped in the middle. As long as the system pressure remains high enough, some water still forces its way through that constricted segment. But if overall pressure falls, flow through that bottleneck can drop to virtually nothing, especially if a small clot has lodged there and the system lacks sufficient force to push it along. At night, while you sleep, blood pressure naturally declines by roughly 15 to 20%. This is a normal physiological dip, not a disorder. If you already have a plaque-narrowed artery, that nocturnal drop can be enough to convert a partial obstruction into a complete one, particularly if a clot has formed on that plaque while you were lying quietly. That's one reason some people retire to bed feeling perfectly well and awaken with stroke symptoms, or are discovered that way in the morning. Age plays a role, but not in the simplistic, stroke only happens to the elderly manner you hear at family gatherings. Yes, stroke risk increases markedly after roughly 50 and approximately doubles with each additional decade. In older adults, the predominant culprits tend to be atherosclerosis and plaque accumulation, alongside long-standing hypertension and heart rhythm abnormalities. But approximately 10 to 15% of strokes occur in people younger than 45. In those younger patients, the records reveal different underlying drivers: congenital vascular abnormalities, bulging weak spots in vessel walls known as aneurysms that can rupture, clotting disorders, autoimmune diseases, and trauma to the head or neck. Another point worth grasping: the pace of vascular damage from the same risk factors changes with age. After roughly 40, plaque accumulation and endothelial injury from factors like smoking, elevated sugar, or high pressure tends to proceed at about double the rate it did in your 30s. That's one reason physicians become more insistent about risk factor management as patients progress through their 40s and 50s. So let me put a question to you. How old are you right now? Your age influences how rapidly your vessels respond to the same risk factors and shifts which stroke mechanisms are more probable in your particular situation. That genuinely matters for what you and your physician should be monitoring. Now, the most actionable segment. What do you do if you've already experienced even one of those 5 warning episodes, even if it felt minor and vanished in under 10 minutes? You have approximately 72 hours during which a great deal can still be accomplished to head off a full-scale stroke. The objective isn't to panic, but equally not to waste that window. Stroke specialists frequently emphasize the importance of not being entirely alone following a suspected transient attack. This is worth discussing in advance with your family and your physician, particularly if you live by yourself. If another more severe episode occurs and you suddenly can't speak or move, you need another person who can witness it, contact emergency services, and reach you quickly. Many people find it helpful to inform someone close to them about what happened, and ensure that person can be reached easily over the next couple of days. That's a reasonable topic to raise with your healthcare provider. Stroke guidelines also counsel against driving yourself after a possible TIA. Losing vision or arm control for even a few seconds at highway speed is life-threatening for you and everyone else on the road. It's worth arranging in advance with your doctor what transportation plan makes sense in your situation should something like this ever occur, so you're not tempted to simply drive yourself in. Measuring blood pressure is typically among the first steps in virtually any acute situation. If you or someone nearby can take a reading and the upper number, the systolic pressure, reaches approximately 180 or higher, and the lower number, the diastolic, reaches approximately 110 or higher, that fits the profile of a hypertensive crisis, not merely elevated blood pressure. A crisis of that magnitude is itself a strong harbinger of stroke, and contacting emergency services immediately is what standard guidelines typically recommend. Ask your doctor explicitly about this threshold so you know in advance when to treat it as an emergency. One rule from stroke medicine is absolute. Never initiate blood-thinning drugs like aspirin, anticoagulants, or similar agents on your own, based on a friend's suggestion or something you encountered online. There are two main types of stroke: ischemic, where a vessel is obstructed, and hemorrhagic, where a vessel is bleeding. Thinning the blood can be beneficial in certain ischemic scenarios, but in a hemorrhagic stroke, it can accelerate and enlarge the bleed, which can prove fatal more rapidly. The only reliable way to distinguish between the two is brain imaging, typically a CT scan in a hospital setting. No physician can examine someone and be entirely certain which type is occurring without a scan. So rather than self-treating, the correct course is to get evaluated and let a medical team make the determination. You can certainly ask your doctor in advance how they'd want you to respond if you ever suspect a stroke. While awaiting help or en route to care, body positioning matters. Lying down is generally preferable to sitting bolt upright because it promotes blood flow to the brain. Many clinicians recommend a comfortable, flat position with the legs slightly elevated above chest level to support circulation and reduce the heart's workload. The head should be kept neutral, not bent sharply forward or thrown backward, so the neck vessels aren't compressed. It's also prudent to avoid cigarettes, alcohol, or exposure to hot baths or very hot showers in that moment, since sudden vessel dilation in an already unstable circulatory state can worsen the situation. Verify this with your own physician. Maintaining a written list of all medications you take regularly, stored somewhere easy to locate, is a small measure that can save critical minutes for emergency responders. One thing many people get wrong: if 72 hours elapse and no new episode materializes, that doesn't mean the danger has passed. It means you were granted a second chance, and you still need to act on it. There are 3 evaluations that are entirely reasonable to request at your next medical appointment if you've experienced any of these warning signs. Each examines a different piece of the stroke puzzle. The first is a specialized ultrasound of your neck arteries called a carotid duplex ultrasound. Unlike a basic ultrasound that merely reveals structure, duplex imaging shows both the anatomy of the artery and how blood is moving through it, including whether flow accelerates and becomes turbulent at a narrowed segment. If the carotid artery is narrowed by more than roughly 70% due to plaque, physicians call that a hemodynamically significant stenosis, meaning the constriction is severe enough to seriously impede blood flow. At that threshold, the question shifts from, "Will a stroke ever occur?" to, "When will it occur if nothing changes?" That's why surgeons may recommend a procedure called carotid endarterectomy, in which they open the artery and extract the plaque. It sounds dramatic, but in contemporary practice, it's a routine operation that spares tens of thousands of people from stroke each year. If you have risk factors or symptoms, raising the topic of carotid ultrasound with your doctor is a worthwhile conversation. The second test is a blood assay called glycated hemoglobin, or HbA1c. This is ordinary hemoglobin, the oxygen-carrying protein in your red blood cells, that has sugar molecules bonded to it. The higher your blood sugar has been over the preceding months, the greater the proportion of your hemoglobin that becomes sugar-coated. That's why this test reflects your average blood sugar across roughly 3 months, rather than just a single morning snapshot like a fasting glucose test. You can't fake a favorable HbA1c with one perfect fasting result the day before the blood draw. It's especially adept at detecting that gray zone called pre-diabetes, where sugar has been elevated long enough to damage vessels, but nobody has applied the diabetes label yet. The thresholds are clear: Glycated hemoglobin below approximately 5.7% is normal. 5.7 to 6.4% falls in the pre-diabetic range, and 6.5% or above generally indicates diabetes. If you've never had this test, or it's been years, that's a simple item to bring up with your physician, particularly if you carry any stroke risk factors. The third investigation is Holter monitoring of the ECG. In plain terms, a 24-hour heart rhythm recording. Instead of a 10 or 20-second electrocardiogram captured in the clinic, you wear a small, portable device for a full day while going about your normal activities. The rationale is straightforward. Certain dangerous heart rhythm disturbances are intermittent. They might surface once or twice a day for a few seconds and be completely missed by a brief snapshot ECG. The chief rhythm offender when it comes to stroke is atrial fibrillation, or AFib. In AFib, the upper chambers of the heart, the atria, abandon their steady, organized contractions and instead quiver chaotically, sometimes at rates of 300 to 400 beats per minute. When that occurs, blood doesn't empty smoothly from the atria. It churns and swirls instead of flowing. And in that turbulent blood, clots form with alarming ease. Those clots can be ejected from the heart, travel upward to the brain, and lodge in an artery. This is called a cardioembolic stroke, and it tends to be severe. Many people with atrial fibrillation don't experience dramatic symptoms. At most, they notice occasional skipped beats, brief fluttering sensations, or they attribute it to stress or caffeine. Holter monitoring is what uncovers these hidden episodes. If AFib is identified, there are well-researched medications called anticoagulants, blood thinners, that, when prescribed and supervised correctly, can reduce stroke risk in this condition by roughly 60 to 70%. That's not an inevitable fate. It's a risk that you and your cardiologist can actively address. Taking a step back, stroke is not a bolt from a cloudless sky. It's a foreseeable event that typically follows years of silent vascular damage, and it frequently announces itself in advance. You now know the major signals: brief blindness in one eye, sudden one-sided numbness or tingling, abrupt loss of coordination or an unsteady gait, sudden severe breakdown of speech, and vitiligo accompanied by new atypical headaches. Any of these appearing for the first time, even if they disappear within a minute, constitutes a reason to consult a doctor urgently and inquire about those three evaluations: carotid duplex ultrasound, glycated hemoglobin, and Holter ECG monitoring. On the prevention front, there are measures that research links to reduced stroke risk. Keeping blood sugar within a healthy range and identifying prediabetes early safeguards the endothelium and decelerates plaque growth. Managing blood pressure in partnership with your physician, not just driving it down at all costs, but avoiding both extremes, lessens the strain on your vessels and lowers both hemorrhagic and ischemic risk. Quitting smoking, with professional support if necessary, removes a relentless chemical assault on your arteries and cuts your ischemic stroke risk by roughly a factor of 2 to 4 over time. And the most essential point to absorb: don't wait for brief brain symptoms to resolve on their own. In the world of stroke medicine, you have approximately 72 hours to act. Here's what to do after watching this. If you recognize any of the 5 warning signs from your own experience, even from months ago, write them down in plain language and bring that list to a physician. Don't trust your memory alone. Ask directly whether you should be assessed for transient ischemic attacks and whether carotid ultrasound, glycated hemoglobin, or Holter monitoring is appropriate in your case. If you carry risk factors such as elevated sugar, high blood pressure, smoking, or autoimmune conditions, use what you've learned here to have a more targeted conversation with your doctor about stroke prevention, rather than departing with a vague, "everything looks fine," and no concrete numbers. Everything we covered today is intended for your understanding and education. Your situation is unique to you, and using this as a springboard for a genuine conversation with your physician will always be more valuable than attempting to manage things independently. If this made a complex subject easier to follow, subscribe and tap like, and share this with someone whose brain you'd like to keep functioning well. That's no small thing. I'm Dr. Dan Carter. Look after yourselves. I'll see you in the next one.